While our previous lecture talked about ST segment changes in coronary ischemia, this session will explore ST segment changes due to other pathologies. At the end of this lecture, you will be able to describe the changes in the ST segment that will be seen with some common electrolyte abnormalities and some toxins. Again, just to remind us of our systematic approach, in this lecture we're going to focus on the ST segment. At the very end of the lecture we'll talk a little bit about P waves and abnormal ectopic beats. If your patient is in cardiac arrest, of course we're going to deal with that first. Similarly, if the patient is unstable, we have to stabilize them before focusing on the ECG. And just a reminder, our ECG must always be interpreted in conjunction with our clinical history, examination, and cardiovascular assessment. We're going to talk about high and low potassium and high and low calcium. So these are the changes that you're likely to see with hypokalemia. The patients develop a secondary repolarization wave after the T wave, which is called the U wave. With progressive hypokalemia, the T wave then flattens and the U wave becomes taller. And if you think about those two things in combination, we eventually end up with a prolonged QT interval, which is one of the hallmarks of severe hypokalemia. With hypokalemia, we have a series of changes that go from early changes, peak T waves. Remember, we spoke about peak T waves as also being seen in hyperacute ischemia. There's a slight difference. The peaked T waves in hypokalemia tend to be broad-based, whereas the peaked T waves in ischemia tend to be narrow-based. Later, we develop intraventricular block with progressive widening of the QRS complex and flattening of the P waves, which eventually morphs into a broad sinusoidal type of wave pattern with severe hypokalemia. You will see correlations between the changes in the ECG and the severity of hypokalemia. While this is a good marker of what may be going on, bear in mind that these changes are not consistent or reliable because they also depend on other things such as the presence of acidosis, other electrolyte imbalances, and possibly even drugs used to stabilize the myocardial in the membrane. In hypocalcemia, the key things are a shortened QRS duration and a prolonged QT interval. The PR interval may also be shortened and the T wave may also be flattened. Whereas in high PER calcemia, we get a widened QRS complex, a short QT interval, and a prolonged PR interval. We're now going to proceed to talk a little bit about the changes seen with some drugs. Let's start with digitalis. So digoxin toxicity is still something that we fairly commonly see because we do have patients with atrial fibrillation who are being controlled on digoxin. And some of the changes we see is ST segment depression, upsloping ST segment depression, a shortening of the QT interval, low amplitude T waves, and a shortened PR interval. With increasing severity of toxicity, patients may develop ventricular ectopic beats, bigeminal rhythm, and bradycardia. It's important to identify the non-cardiac signs of digoxin toxicity when dealing with patients on digoxin, because sometimes these may either precede or portend the ECG changes, and these may often include nausea, vomiting, and visual changes, particularly colored halos around objects in the visual field. Quinidine can sometimes be seen in toxic doses, and this can lead to a prolonged QT interval, widened QRS complex, and the development of Q waves. It should be noted that actually patients who are on digoxin who then start on quinidine, because they share the same excretory mechanism via the biliary system, that quinidine can potentiate the toxicity of digoxin. Phenothiazine overdoses are commonly seen, and as with many anticholinergics, what you see with phenothiazines is a prolongation of the QT interval, ST depression, the development of U waves, and low amplitude T waves. And if you think about that, they may tend to mimic what you're seeing with hypokalemia. We will talk a lot more about tricyclic antidepressants. This is one of the drugs that you need to know everything about, and you actually need to know the ECG changes in detail. We're just going to touch on them today, but you really need to know them. The first thing to say is that the commonest and earliest ECG sign on a patient with tricyclic overdose is simply sinus tachycardia. As the toxicity progresses, the QT interval begins to prolong and the QRS complex widens. And then later changes may mimic what we talked about with phenothiazines. We actually have a lecture on tricyclic overdose and in the toxicology section, and we talk a little bit more about the ECG changes there. Having looked at the QRS complex, we need to touch on the P waves and really tell the difference between left atrial hypertrophy and P mitrale and right atrial hypertrophy and P pulmonale. This sometimes gives us a clue to the presence of right or left ventricular hypertension and AV valve stenosis or regurgitation. And finally, we need to think about ectopic beats and how we differentiate supraventricular from ventricular beats. So ventricular ectopics tend to be wide complex, although it should be borne in mind that beats generated far enough up the conducting system, for example, beats generated from the bundle of His, may be narrow complex. Critically, because these ectopic beats don't interfere with the firing of the SA node, there is no compensatory pause between the ectopic beat and the subsequent normal beat. So the interval between this beat and this beat will be twice the normal heart rate, and that's because somewhere here there's a beat that is swallowed up by this ectopic. Whereas in supraventricular ectopics, the complexes are by and large narrow unless there's a concomitant bundle branch block, but usually narrow, and there is a compensatory pause. That is to say, here's your last normal beat, this is your ectopic beat, this is your next beat. If you look at this interval, it is more than just 2 beats. So, and that's because this beat was generated supraventricular and the SA node would have been depolarized and has to reset before it starts back. If the beat is from the AV junction itself and then being propagated retrograde through the atrium, you will not see a P wave at all. If the beat is coming from somewhere within the atrium, the P wave will be abnormal and usually is represented by a inverted P wave or a P wave with an abnormal axis. So that was your lecture on ST segment changes other than ischemia, plus a little touch on P waves and ectopic beats. If you have any questions, you can post them on the WhatsApp group or bring them to our Wednesday sessions. Just to remind you of how we approach this, look at the patient, look at the rhythm, look at the QRS complex and axis, then the ST segment. and finally the P waves and any abnormal or ectopic beats. Our final lecture will be on cardiac rhythms.